Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Farden. I'm the chair and organizer of Grand Rounds. I'm always on the scrounge to people to give a talk at Grand Round. We've had a good program in January thus far, and I have slots though opening up into February, March, April. There's plenty of slots taken in May. I think people realize there's a bit of time to plan. But if you do have a talk that you've got in mind, or you know someone who will give a talk, then please do get in touch because we've got slots as early as the 19th of February to fill up. So please do get in touch with anything at all, anything you think will be of an interest to a general audience. And on that, Lauren contacted me, I think before Christmas, to offer her services at Grand Round. She's a recently started consultant medical oncologist here in NHS Tayside, who is also the clinical lead for immunotherapy in the cancer services. And I think for those of us who are in sort of general medical specialties, general practice, and I suspect the other directorates as well will see increasing use of immunotherapy. It's a bit of a dark art to us. These drugs are incredible in their efficacy. In fact, I think our second grand round of this sort of iteration of it back in 2015 was the dermatologist talking about Pembrolizumab. So that we're coming for sort of full circle 11 years later to talk about perhaps the next generation of these treatments. But they're amazing and have revolutionized cancer services, but they're not without their complications, and those complications do present to general medical services. So it's important to know what you need to know. So Lauren is going to talk about immunotherapy toxicities, anti-cancer immunotherapy, and everything that you need to know. So if you have any questions, please do put them in the chat, or you can wait until the end, stick your hand up and do it in person. Usual Zoom rules apply. Mute your microphone, but feel free to leave your camera on if you wish. Lauren, thank you very much indeed. Looking forward to your talk.
Thank you very much, Tom. Thanks for a lovely introduction and for covering a lot of the reasons why I wanted to do this talk. Today we'll be covering immunotherapy, a wee bit about what it is, and also about the toxicities, which I think is just, important for us all to hopefully know just a tiny bit about, even if it just is to let us know about them. As Tom said, my name is Lauren Cammaert. I'm a consultant medical oncologist in NHS Tayside. I've done all my training in the north of Scotland, really, other than a short stint in the central belt at the Beatson. I've worked in NHS Grampian up until recently, and everyone has been very welcoming to me in Tayside over the past couple of months. So just click through. So this is what we're going to talk about today. So I'll try and keep it brief. No one wants to listen to me harp on for longer than about half an hour. But what I'll do is I'll talk to you about why I'm so excited about immunotherapy, why I'm passionate about it, why I do my job, and when we use it, toxicity profile, some presentations to be particularly concerned about. I'll touch on a bit of toxicity management, which is very, very difficult and complicated. I'll touch on some of our more complicated immunotherapy regimes and then go on to some take-home points. So hopefully I can keep this interesting for you. So first off, the why. Why are we excited about it? Why did I want to come and talk to you about it today? So this is a good old Kaplan-Meier curve. We love those as oncologists, and it touches on a drug regime very similar to what Tom spoke about to start with. So pembrolizumab and melanoma. Well, this is ipilimumab, nivolumab, and melanoma. So when I first qualified back in 2014, I worked in an elective orthopedics ward. And I saw lots of patients getting really horrible, really morbid metastatectomies for melanoma. And as you may know, metastatic melanoma, it's a disease of all ages, but of cancers that affect young ages, melanoma is one of the big ones. So I just saw horrible, horrible situations of people having large tumors being cut out, people bleeding to death. It just really horrible ends of people with melanoma and being told that you would have about 3 months when you're diagnosed with metastatic disease. So it just seemed really grim to me. And then I moved on to work in oncology, and just around that time is when nivolumab was first licensed. Prior to that, we'd had a bit of immunotherapy with ipilimumab on its own, which is quite a toxic treatment. But we went from having patients who were dying almost invariably within 3 to 6 months and no good treatments to patients who, I mean, look at this slide. So patients who have immunotherapy, a combination regime, having a 58% 3 year overall survival. And it soon became clear that the people who were alive at the 2, 3 years have this tail of the curve phenomenon. So these people are staying alive, and potentially soon we can say some of these people are cured. So to go from a disease that was almost invariably fatal to a disease where we're, for all intents and purposes, probably curing about half of the patients, that is absolutely huge. And I don't think there are many, you know, potentially fatal conditions that have seen that kind of turnaround in management in the past 10 years. So that's why I'm passionate about it. It's amazing. It's so amazing to see patients be in really dire straits and not being sure if they're going to see their kids last through primary school to seeing their kids actually getting into uni. It's amazing. But that's not to say it's without its problems. And that is why I have a job as immunotherapy lead. So again, why we're excited about it, this is all the things I've said. Um, we're not always sure who's going to benefit from it, but there's work taking place there, and we can maybe come back to that a little bit later. So I've jumped ahead of myself. I used to describe immunotherapy first, but I think to get you hooked in, it's important to know why it's great, why I think it's such an amazing course of treatment. The other thing to know is actually, as oncologists, we don't prescribe all that much chemo anymore. So immunotherapy, which is, when I say immunotherapy, I mean checkpoint inhibitor drugs, which I'll come on to talk about in a second. Checkpoint inhibitor drugs and targeted treatments make up more than 50% of our systemic anti-cancer treatments now. So in my role as a melanoma oncologist, I don't prescribe any chemotherapy at the moment. So it really is a shift change in the oncology world over the past decade. So this slide, this is the little medical oncologist Bible. So this is a landmark hallmarks of cancer paper. So this is looking at all of the different targets that we can use with our systemic anti-cancer treatments to try and induce a response in patients with cancer. So when I talk about immunotherapy can mean so many different things depending on what discipline you work in. But in oncology, immunotherapy, or IO as we shorten it to, is when we're targeting the part of the cell that's avoiding immune destruction. So here, I mean, this is an old slide. This is back from 2011. So this is when we only had ipilimumab, which is an anti-CTLA4 monoclonal antibody, which CTLA4 is one of the checkpoints on T cells where cancer cells can try and avoid immune destruction. Okay, so all of these other things here, we also have other targeted treatments for, but avoiding immune destruction is what we're going to focus on today. So let's take a step back. What is immunotherapy? So I'm sure that some of you will know this in a lot more detail, but just kind of taking a broad strokes approach and keeping things basic, which is the way I usually like to approach anything difficult. So completely different from chemo, works in a completely different way. It still comes under the umbrella of what we call SACT, so systemic anti-cancer therapy. It activates your immune system, so it activates T cells. So our immune system, our T cells, we're always on that kind of, I guess, that tightrope of being, we don't want our immune systems to be so active that we push towards autoimmunity, but we don't want them to be so inactive that we can't fight off any infections, any cancer cells. What happens when cancer cells can grow and develop is they kind of tip backwards. So they tip away from the autoimmunity and tip towards the T cells becoming a little bit more inert. So what our treatments do is they counteract that. So they inhibit the checkpoints where cancer cells are down-regulating our T cells and our immune system. So I can't say we don't have neutropenia, because we do have the odd case of autoimmune neutropenia that is very small print. But for all intents and purposes, we don't see neutropenia with this. It doesn't increase your infection risk. As I said, it allows your own immune system to sort of attack, kill cancer cells. It's not directly cytotoxic. So this is a monoclonal antibody that's stimulating your body's own immune response. The responses we see are very variable, much as our own immune systems are very variable. So we can see delayed responses, we can see really quick responses, we can see a flare phenomenon where your immune system is upregulated, T cells invade into tumors, cytokines cause inflammation. We get a flare of a tumor, a growth of a tumor before it shrinks down again. And I'll show you some images a bit later on that just demonstrate that. And there's multiple different types. So there's multiple different checkpoints. We only know about a few of them. But the ones that we focus our medications on at the moment are CTLA4, which is a drug called ipilimumab, some of you may have heard of, and PD-1, which almost all of you will have heard of some of the PD-1, PD-L1 checkpoint inhibitors. So I've got some names of the different drugs down here. Don't need to focus on them too much, but pembrolizumab and nivolumab are probably the most well known. But we also have some other ones, durvalumab, atezolizumab, avelumab. We love a complicated drug name in oncology, as if anyone is on social media seeing memes about oncologists, we're just random word generators for the most complicated things possible. But for all intents and purposes, nivolumab and pembrolizumab are the ones we use the most. Some of these drugs are actually coming off patent. So nivolumab and ipilimumab are coming off patent soon, which is amazing because that will take the costs down and make these drugs a lot more accessible across the globe, which is excellent. So this is a nice slide. This is quite old. I've recently revamped this talk, but I've been giving it since 2019. So this is just a slide that shows checkpoint inhibition in action. I could probably find a better one now. When do we use immunotherapy? So we're using immunotherapy in lots of different cancers now. So as I came through my registrar training, predominantly we were using it in melanoma, lung cancer, and renal cancer. So it became very, very quickly the mainstay of melanoma management. It's pretty much a mainstay in lung cancer management as well. But actually now, in the past few years, we have seen indications come up for almost every single cancer. And the indications are a bit more complicated. We used to just use one immunotherapy drug on its own, say nivolumab or pembrolizumab. Now we're using really complicated combinations with chemotherapy. And lung cancer is obviously relatively common. Melanoma is not particularly common, but we're starting to use these drugs in the really common cancers. Like it's now licensed in early breast cancer, which is by far and away the single most common indication for systemic anti-cancer treatment. So the fact that it's now getting into that means it's something that a lot of us are going to see these patients. Okay. So as Tom said back at the start, we started using pembrolizumab in 2015 for melanoma. So that's why you had dermatology coming to talk to you then. I wonder if that was Professor Proby. We had it licensed in lung slightly later. Nivolumab, I think, was around 2015 as well. And we can also give combination treatment with a couple of these different drugs. Now, want to get onto the more juicy part of this, which is the toxicity profile. So immunotherapy is amazing. It's revolutionized cancer care. It keeps people alive. It is fantastic. And for most people, it doesn't cause any problems. If you are somebody who's coming to my clinic and I'm discussing giving you single agent pembrolizumab, for example, as adjuvant treatment for melanoma, which I'll be seeing a few people for later this afternoon, I would tell you that you have a greater chance than not of having no side effects whatsoever. So an intravenous treatment every 6 weeks, and the chances are you won't have any side effects at all, not even tiredness, amazing. But the trade-off for that is there are a small number of patients who will get really severe toxicities, some of which can be life-threatening and life-altering. Okay, now they are the 1%, but probably about 1 in 3 to 1 in 5 patients will get some side effects of some description. Okay, and they can be anywhere from grade 1 to obviously grade 4, the really, really troublesome ones. Now, the tricky part is you can get a side effect of almost anything. I don't actually list side effects for patients anymore because I would be there all day. So you can get, if you imagine, so the way that immunotherapy can cause toxicity is by flicking that switch towards autoimmunity. And we all know that autoimmune conditions can affect almost any organ and tissue in the whole body. So it can affect any tissue from your skin, causing rashes, vitiligo. It can affect your eyes, it can affect your sinuses, it can affect your lungs, your various endocrine organs. It can affect anything. But some presentations are more common than others. Some things we'll see on blood tests. So one of the most common side effects we see is that your thyroid can be really quite profoundly affected. So In the literature, it's reported to be about 1 to 7% of patients get endocrine toxicity, but we know from real world audits, it's probably about 10% of patients get what we see is a bit of a thyroiditis. So patients get raised T4, then it crashes down, and it's very, very quick. Our patients get blood tests between every 3 weeks and every 6 weeks, and you can see someone's T4 go from 12 to 40 to 9 to non-existent in the space of a month. It's pretty crazy. And that reflects how much your immune system can be activated. And the side effects can be very, very brisk. So much more brisk than you would expect a normal autoimmune disease to present. And that's because it's mediated in lots of different ways, including T cell destruction of tissues, not just autoantibody formation. So most it sounds really terrifying, and that's why I don't list all the side effects. Actually, the majority of side effects are mild. So most common would be a skin rash, a bit of an itch. Then it would be your thyroid problems. And then we run into things like colitis, hepatitis, pneumonitis, most of which are pretty mild, okay? But we do see some life-threatening side effects with these, okay? So what I say to patients is we will catch some of these on blood tests before you'll even notice them. We will take you in for treatment and you'll feel like a fraud, but we need to get you on treatment early to stop things becoming worse. But some things you'll need to tell us about. So, of course, I'm not going to catch colitis, I'm not going to catch pneumonitis on blood tests. So, what I say to patients is any new symptom, you know your own symptoms, you know what caused you to present with this cancer. Any new symptom for you, we want to know about it right away. And the reason that we're so prescriptive about that is some of our most serious toxicities can present in a really, really benign fashion. So, what often tends to happen is you just have this generalized inflammation in your body to start with. So, general T cell activity, cytokine production. And what you can feel is a little bit fluey. Unfortunately, immunotherapy, the fatal side effects that can happen are things like myocarditis, cytokine release syndrome, HLH. Please don't ask me to say the real words in HLH. You can see autoimmune neurological conditions like Guillain-Barré. And what is in common with all of these is to start with, rather than having the normal organ-specific symptoms, often what people feel is really profound fatigue, like I cannot get out of my bed fatigue, and often a sense, that sort of sense of impending doom that we talk about. You can have a bit of that. You can have a sense of, something is just really not right. That I have seen anecdotally in all my myocarditis patients, apart from one, is that they just know that something is not right, but they can't put a finger on it. And I tell patients to take that really seriously, and I really take their instincts seriously. Okay. So basically, any itis. Okay. Presentations to be particularly concerned about are, like I say, so fatigue, that something is wrong, I can't put my finger on it, I'm really fatigued. Refer those patients to oncology without delay. We'll do a full set of bloods because what we want to look for are markers of things like myocarditis. We want to do troponins. We want to look for things like myositis, do a creatine kinase. We want to check cortisol, check thyroid functions, basically do a really, really comprehensive panel of bloods, do a proBNP, again, looking for myocarditis, looking for heart failure. If patients are really sick, so I did a presentation recently to critical care, and so obviously the presentations to be concerned about are going to vary depending on where you are. But someone who is really, really sick and you can't put your finger on why, and you look into their notes and you see that they have had cancer treatment within the last year, please get in contact with us, because we know that about half of these patients will have had immunotherapy of some description, and immunotherapy side effects can happen at any time. So they don't just happen when you start treatment, they can happen anywhere from the day after you have treatment to 18 months after you finish your treatment. Okay. Now, in practice, I haven't seen anyone present longer than 6 months after their treatment. But what we do see is that surgery, concurrent illness with things like viruses, COVID, can precipitate an immune reaction happening again, even well after someone has stopped their immunotherapy. So profound fatigue, if someone is really hypoxic with no clear cause, or they're unwell and septic, they could actually have, something like a systemic inflammatory syndrome, profuse diarrhea or severe abdominal pain with fever, generally unwell with hypotension, postural drop. That could be someone having something like a hypophysitis or inflammation of their adrenal gland. of course, anyone, like I said, anyone admitted to critical care or any weird thing you just aren't sure about. So sometimes mild things can really cause significant morbidity in these patients. So, you can get really significant sinusitis, which is not very nice. You wouldn't think of, oh gosh, I must refer this patient directly to oncology, but actually get them started on some saline nose sprays. I've lost count of the people who I've caught with that other people haven't realized it's immunotherapy toxicity. And patients really, really thank you for prescribing them a nose spray in that situation. So there's some really quick little easy wins. So this is just an illustration of one of the first patients I saw with immunotherapy toxicity. So this was back when I was a registrar. This was a lady who I saw back in, I think, maybe 2018. So I was on call and it was weirdly quiet. So I decided to look at the medical HDU board, always a mistake. I saw a lady's name who I'd seen in another consultant's clinic a couple of weeks beforehand. I had a look at her notes and saw she'd been admitted with a very odd picture. They weren't sure if it was infection, inflammation. She'd stage 4 non-small cell lung cancer, which was locally advanced but not metastatic, and a very high PDL1. So she'd recently started Pembro as a first line. She'd been admitted to medical HDU after a short history of shortness of breath at home, and they were treating her for infection. Now, she'd been treated for infection for about 4 days, and unfortunately, her oxygen requirements had been escalating over that time up to about 15 litres. We started IV methylprednisolone, which I'm ahead of myself before we talk about management, which is our normal management of patients with toxicities. But unfortunately, it was a wee bit too late for this lady. So it's just really to illustrate that sometimes you can have really severe side effects that can happen quite quickly. She'd only started her drugs a few weeks beforehand. And we know that patients who have side effects, we need to get them started on treatment quickly, because once the immune system starts reacting, it just potentiates and gets harder and harder for us to dampen down. Okay. This is colitis. I'm going to tell you more about this lady a bit later on in the presentation. So 52-year-old woman with metastatic melanoma. She just had her third dose of 2 immunotherapy drugs together, ipilimumab and nivolumab, which we call ipi-nivo. She initially presented with pyrexia and abdominal pain, which isn't how you'd normally think of colitis. So she was sent home from A&E. The next day she was brought in, we decided to do a CT of her abdomen. It showed quite a bit of transmural thickening in her transverse colon, and there was some X-ray evidence of colitis as well. You can see a bit of thumbprinting there. So our management, again, we'll talk about that in a little bit, is steroids. I told you it was complicated. You'll have noticed I've said steroids twice already. And that's the mainstay of our toxicity management. So it's actually really not hard. If I could only have 2 drugs, it would be prednisolone and MMF, I think. That's the mainstay of how we manage these patients. So any toxicity whatsoever, it's almost always, apart from a few caveats, and one of which would be worsening of psoriasis, almost everything else we manage with steroids, okay? So that's oral or intravenous steroids, and the things I get excited about are who we can get away with low dose and who we need to hammer with high dose, because the principle is we want to try and get on top of this excess immune activation as much as possible. We're not going to dampen it down to 0. We're not going to stop it being effective on cancer cells. We just want to kind of scrape the immune response off the ceiling and take it down to about here, where it's still going to be, your immune system's still going to be exhibiting an anti-cancer effect, but it's just going to take you away from being tipped fully into the deep end of on autoimmune response, okay? So most of the time we can get on top of that with prednisolone, but sometimes we have to come into our steroid-sparing agents and other monoclonal antibodies, like infliximab and things like that. If we can try and get away with steroids, that is absolutely best. But the longer it takes for us to start the steroids, the more likely the side effect is likely to be steroid unresponsive, which is obviously bad news. So the best thing to do is try and give a short duration of very high dose steroids. And I'm not going to go into too much detail with that, because that's for us to do. It's really just kind of to get an awareness out there and to know anything odd, a patient who's had a checkpoint inhibitor, just get them through to us, because time matters in terms of getting them started on their treatment. So we've been over the management, which is steroids, and more steroids, sometimes a bit of a steroid sparing agent. Now, just to mention a couple of groups of patients we need to be even more concerned about. So, anyone who's on immunotherapy, if you see they're on two MABs together, so the only combination regime we have of just the two MABs together rather than chemo and a MAB is ipilimumab, nivolumab, and they have a much, much higher rate of side effects. So, rather than being, about 1 in 3 patients having a side effect of some description, most of them grade 1, half of these patients will need to be admitted to hospital because they have significant side effects. Now, this isn't a regime that has historically been used very much, but it's something that we will be using a lot more of very soon. So almost everyone will experience some sort of side effect, and half of them will be grade 3, grade 4. So we really need to know if these patients are admitted to hospital. They should come through acute oncology services, but sometimes because these patients are now often on neoadjuvant pathways, they'll be getting surgery. After they have surgery, they're not really thought of so much as an oncology patient. So I have seen that these patients, they end up in acute medicine, they end up in A&E, they end up in surgery, GP. So always just let us know about them. So again, that's just illustrating the number of side effects, and unfortunately that we do have some treatment-related deaths. And that was one of the reasons that I really wanted to just jump straight into this as soon as I moved to Tayside. Unfortunately, in the past few months, I've seen 2 patient deaths on immunotherapy. It can't always be avoided, but in one of the cases, I think there were probably some things that could have been done better. So, and part of that is just us knowing about the patients. We're not always the best at documenting clearly what patients are on in terms of drugs, so we will absolutely work on that. And we're not expecting other people to know the management. We just really need to find out when these patients are admitted. So I'll skip past this one. So just I'm nearly at the end, you'll be glad to know, but I just wanted to show you a little bit more about a case history of one of the patients who really made me decide to become a melanoma oncologist and be an immunotherapy specialist. So this lady was one of the first ladies that I managed kind of almost entirely, not on my own. Obviously, I was a registrar, I had consultant oversight, but day-to-day management. This lady was admitted every single time I was on the ward, and she started to have just whenever she'd see my face, she would cry because she was always coming in ill to see me. So this is a lady who had 50, she was 52, and she previously excised melanoma. And in June 2019, she presented with a niggling cough. She was due to have a routine surveillance CT scan and unfortunately picked up metastatic disease. So here you can see some metastatic disease in her lungs. So she was admitted to hospital. She had the X-ray that I showed you a little bit before with colitis. So we had recently started her in clinic on ipilimumab and nivolumab, which is our gold standard treatment for metastatic melanoma. And she had just started treatment. She came in with a significant side effect, and we had to do a CT scan to just have a look. She's the lady who came in with abdominal pain. So we did a CT scan of her abdomen, but it covered her lung bases, and this is what it showed. So it showed an interval increase in size of her lung mets. So obviously someone who's presenting really unwell, they've got progressive disease, that's going to impact on some decisions you make in terms of your escalation, isn't it? And that's kind of why I'm mentioning this. And I'll talk a bit more about that when I finish the case study. So you can see here that there's disease progression has been reported on her CT scan. And she's come in with serious colitis, and she's only had 2 doses of treatment. We normally give 4. So you're thinking, this is bad news. So we skip ahead a little bit. So actually, no, yes, so this is again just a little bit more about that CT report, which is also showing the colitis. So colitis, progressive disease, obviously we're worried. Now, skip ahead to November. So in the meantime, we've treated this lady with high-dose steroids. We've given her infliximab, which is what we do when we have steroid-unresponsive colitis. We haven't given her any more immunotherapy. So she's only had 2 doses of immunotherapy. Now, this is November 2019 when we're doing her next CT scan. We're doing it a little, we normally do CT scans every 3 months. We've done this in 2 months because we've been a bit worried about her because the last CT showed progression. Or did it? So we look at this now. So now she's got a small subpleural nodule rather than the bulky pulmonary metastatic disease that we saw before. But this lady also had liver mets. She had spleen mets. She had some small bony mets. And you'll notice on this report here, it's all melted away. So she pretty much has no evident disease. And this is a lady that just 2 months ago on her CT scan, it showed progressive disease. So if you'll remember right back at the start, I said that you can see a flare phenomenon. We commonly see that with melanoma and we commonly see it with lung. So if someone is on treatment and within the first 6 months, their CT scans are showing progressive disease, we always take that with a grain of salt because actually these patients can then go on and have excellent responses. And if these patients have excellent responses, think back to the graph I showed you at the start with the Kaplan-Meier curve. Most of those patients who are disease-free or stable disease at 2 years, about 80 to 90% of them won't go on and have any disease progression. I think in the coming years, we're going to be able to say some of these patients are cured. So when these patients present sick with immunotherapy toxicity, please bear in mind when thinking about their escalation. Now, obviously, we're usually going to be involved, but in the middle of the night, please refer these people for discussion with critical care because although it might look like they've got progressive disease, be wary, it could be a flare. And of course, you can always discuss that further with us. So that lady, that was 2019. She lives in the next town over from me. I quite frequently see her. She's seen her daughter graduate uni. She's back to work. She had quite significant toxicities. She unfortunately developed type 1 diabetes as well, but she's managing that well and she's leading a really normal life. Um, so it's amazing, but it wasn't without issues for her. And what happens after toxicity? So we follow these patients up in our clinics quite closely. In the future, it would be great to have a bit more shared care between specialties. At the moment, as oncologists, I'm an amateur cardiologist, an amateur gastroenterologist, an amateur rheumatologist, but it would be so great to have more of an MDT approach, which is another reason of doing these talks to try and gain a bit of visibility, get a bit of interest. And if anyone wants to become involved in my immunotherapy MDT, I would more than welcome you. So we follow them up closely. We try and get them off steroids as quickly as we can. Sometimes we can restart treatment, but we don't always need to. We know that checkpoint inhibitors aren't dose dependent. And the way I describe it to patients is we want to flick a switch. We want to turn your immune system on and get it attacking the cancer. Once it's doing that, we know it's going to keep doing that, even if we stop the checkpoint inhibitors in most people. There's studies ongoing to look at that in a bit more detail. But we know that patients who have toxicities do better overall in terms of their response to treatment and their overall survival. So I always counsel people that at their first appointment to say, please report any toxicities to us because if you have them, it actually means you're going to do better. But we need to get you on treatment quickly so we can get you off the steroids and avoid steroid side effects as much as we can. And just because we might need to stop your treatment, it doesn't mean that you're not going to do just as well as anyone else. If not, actually, you're going to do better than other people. Most toxicities will resolve with steroids alone. Most of them will be really mild. Remember, most patients won't get any side effects at all. But unfortunately, a small number of people will have longer term morbidity and mortality. So it's just really important we know about these people so myself and my colleagues can pick them out, get them started on the right treatment as soon as possible to minimize that as much as possible. And you're all going to see patients coming your way because more and more patients are getting access to these drugs. They're surviving for longer. They're getting them as first line, second line. And remember, unfortunately, one in two of us will develop cancer in our lifetime. So this is something that's going to affect everybody. It's really important to know about, but equally, it's really easy for us to treat because remember, it's just prednisolone, so we can manage these things. So that's pretty much it. That's all I wanted to talk to you about today. Thank you very much for having me. Thank you for listening, and happy to answer any questions if I can.
I'm just turning my camera and screen all back on again. Thanks very much. So the dermatologist spoke about pembrolizumab. It was like I remember distinctly. It was like our second or third grand round in what used to be lecture theatre 2. For those of you long in the tooth enough to remember what lecture theatre 2 was, and I remember being. Well, I remember that in my registrar years, when I did my oncology attachment, that melanoma was a poor outcome disease to have, let's say that, with few treatment options. And then they presented the pembrolizumab data in its early stages. You talking about 10, 11 years ago, and being quite blown away by the change. So here we are talking about the rest of them. But yes, it was pembrolizumab we talked about before. Right, that my waffle has given enough time for a couple of people to have some questions. Jay.
Hi, thank you. That's a wonderful presentation. I hope you can hear me. Yeah,
Yep, yeah, we can hear you, Jay. On you
yes,
go.
it's good. The I mean, it's a wonderful kind of fourth arm in terms of cancer management, and as you can correctly said, more and more specialties are started using this. From a governance and management perspective, we all know this immunotherapy drugs are very expensive and it needs special oncologists, nurses, and maybe pharmacists. This increases the budget and probably increases the workload for oncology. And more multimodality treatments are being used. At least you can see that in the last month it was in the BBC News, like clearly in head and neck, it increases the survival up to 10% after surgery or before surgery. So how do we, as a cancer care, to provide this and choose the right patients? We all know that it doesn't work for everyone. And we, at least for in head and neck, the PDL1 is the kind of the benchmark we to try to use. So what's your view about this? Of course, the chemotherapy drugs are still good, but it's very reasonably cost effective. So it's more like a practical question for the cancer care in terms of organizational.
Yeah, no, you're totally right, and I kind of often joke that you could pay my salary probably about 10 times over just based on the number of people I don't give immunotherapy to on a monthly basis. They're really expensive drugs, unfortunately. However, a lot of them are close to coming off patent, and I think that will make a huge difference. So nivolumab is very close to coming off patent, and that is roughly equivalent to pembrolizumab in a lot of cancers. So I think that will definitely help. But I think we all just have to be a bit, judicious, and with more experience, it'll be easier to know who are the right people to be giving these drugs to, who are the wrong people to be giving these drugs to. There's a lot of work and process with that. But I think it comes down a lot to anecdotal experience, I think, and just more experience we're gaining as we're giving more people these drugs. But certainly in the combination regimes with chemotherapy, sometimes, yeah, we just have to be a little bit, we do have to be careful. I don't think there's a specific answer so far.
Thank you.
And a couple of questions in the chat. No other hands up yet. Tracy says, if you don't mind me asking, you said you don't always know what medication patients are on. Why would that be the case? As they have been prescribed meds during A&E admission or a clinic or somewhere else rather than by oncology, and medical records have not yet been updated, question mark. So what she wants to know why is it not always the case that we know what medication patients are on?
So I think what I was meaning is that some feedback I've had from other medical professionals is that it's not always clear to them what oncology drug they're on. So they might be able to see that they're seeing an oncologist, but not know exactly what drug they're on. So what I was meaning is, sometimes our letters are quite jargon filled, and sometimes it's not always clear from the diagnosis paragraph at the top of the letter. So that's something I've said to my colleagues. But generally speaking, I think most of our letters are really good. And if you look at someone's oncology letters, or what you might see on Clinical Portal is medical note and then clinical oncology. If you click into that, it should tell you what drug they've been given and when. So just if anyone's ill, they come into hospital, you're looking at their Clinical Portal, you see there's an oncology letter, just have a look in those and just see if there's any drugs you might recognize as an immunotherapy. That's really the point I was trying to get across.
Um, there is a separate, is there still a separate note-keeping system for oncology? Do you still use Wisdom and we use everything, we use Track?
Yeah, I don't, so I think all our letters go on to Wisdom. I actually don't have a login for it. I think it's a historical use thing now. I don't think they let new people go on to it. But all the letters from there, I think, do go on, most of them do go on to Clinical Portal. So.
It certainly helps us. Carol has said, thank you. Do you see psychiatric side effects?
So we don't specifically see psychiatric side effects. But what we can see is encephalitis. So I have seen aseptic meningitis and encephalitis a couple times, and I have had animated conversations with people about diagnosing which one it is. And most recently, I had a non-small cell lung cancer patient who was a very heavy cannabis user present with really profound confusion. And I think the feeling was that he was having an acute psychosis and it wasn't related to immunotherapy. However, this man had been on a clinical trial for nivolumab, and it was an observational trial. So he'd been given nivolumab 5 years ago and was one of these patients who had a complete response. But unfortunately, he had a bit more disease, so we re-challenged him. And then he had this really, really frank sort of psychosis. And to me, it was quite evident that it was almost likely to be almost certainly a result of an encephalitis. And obviously the difficulty there is, do you give them steroids, which can then make the psychosis worse? But actually it did settle things down for him. And so the answer is not really. We don't tend to see specifically psychiatric manifestations, but you can, of course, get neurological manifestations, which can be difficult to unpick what's going on.
Where we are, C. Milligan, thanks. Would you say that immunotherapy is contraindicated for patients with pre-existing autoimmune conditions? Does it depend on the condition or severity, etc.?
Yes, so that's a really good point. I hadn't put that in this presentation. Initially, autoimmune disease was a contraindication to getting checkpoint inhibitors, but we are seeing now actually we can be a little bit more bold than we had been before. So not all autoimmune conditions I would worry about in equal measure. Some I'm obviously more concerned about, severe rheumatoid arthritis, severe colitis, things like that. And because it not only increases your incidence of having that condition get worse, but it also means you're more likely to develop other complications too. But what we have seen is that we can keep patients on low levels of their normal immunosuppressive drugs and give them checkpoint inhibitors on top of that. And we can seem to have quite a bit of success with doing that. However, I would judge the risk and benefit individually for patients. So I might not give someone adjuvant treatment in that scenario, depending on how severe their autoimmune condition is. However, if someone's in a situation where they've got metastatic disease and checkpoint inhibitors are their best or their only option, then of course we're much more likely to be able to give it a go.
And then thank you for a lovely talk. We get a number of referrals for endocrine complications and agree roughly 10 to 15% in my experience happy to be involved in MDT. I think that's Icky Malik who's saying that. So that's just a confirmation of chat from an endocrinological side point of view. And I think that may be him volunteering to be part of your MDT.
Excellent. Thank you very much. I'll send you an email.
And if he's not, I'm sorry, Icky, I've landed you in it. Hi, Lauren, great talk. Is the immunotherapy agent important in patients with potential side effects? If asking for advice, is it generally enough to know that they are receiving some form of it or some form of it or number, or is it vital to know which one? Often patients don't know what they're getting. They just say they're getting something.
That's fine. You don't need to know which one. They all do the same things. It's just the incidence of the side effects that differs. So
in general, I mean, a big part of your talk here was that you're very happy to be, as a department, contacted as early rather than late for these patients who invariably attend through ED, out of hours, into AMU, with increasingly specialist problems. Okay. Icky's given you his email address, so there you go. He's landed himself in it.
Thanks. I'll call it up in the chat before I hang up.
Does anybody else have any questions or comments to make about that?
Me, but someone's going to have to tell me how to raise your hand electronically on this thing. I can't find the button, so I'm raising my hand in the old-fashioned way.
You press the button that says react, and then there's raise hand.
React.
Yeah. Never mind. You can practice later.
Anyway, I will do. I mean, for some, as someone in psychiatry, but there have been advances in psychiatry and advances in improved services. We've closed asylums. But it's breathtaking. Listening to and looking at the graphs and seeing some of these advances over the years, say in oncology and hematology, including with the chemotherapies, I think, the older chemotherapy, enormous advances in survival rates, and a fantastic application of basic science. And I think, is it gradually then improving outcomes? And I thought it'd be interesting, but taking taking Jaganesh's point, it raises huge questions about cost, affordability, when's it going to be? But what is it like as a doctor like yourself, say, in oncology, then witnessing a kind of pendulum going the other way, where the senior health policy maker in the world, that dreadful fellow Kennedy, is saying ivermectin's going to be the answer, and joined by celebrities, and a huge big movement of people saying, yes, this ivermectin is going to be the answer to so many cancers. Do you have any comments on that? On how do we change that trend actually that's happening in certain circles, and certainly is going to be, I think, going to get worse and worse in the United States, perhaps followed in the United Kingdom as well.
No, thank you for that. I mean, you're right. It's been amazing to see this pendulum swing, and you do see that. So I think there's a lot of people in, I guess, it's just conspiracy theories, really, isn't it? It's almost that kind of thing. There's a lot of people, I think, who don't trust people in authority, and I think for good reason. When you see, especially during COVID, all the different messages people were given, and I think people are trying to take ownership, and they don't have trust of authority figures, and I think with that it becomes easiest to kind of cling on to the thing that seems most palatable to them, and I think that's where people kind of latch on to all the ivermectin, mebendazole, metformin kind of scenario. They also pay people lots of money to be told to do these things. I have seen quite a number of those patients in clinic who, unfortunately, they often present with quite advanced disease. And I do find that, generally speaking, just a bit of patience and letting these people feel heard, and not kind of coming at people with a hard approach at all, but just gaining trust and taking some time to do that. It takes quite a lot of time, but you can then help these patients to make the right decisions for themselves, which invariably, I've not had anyone in that scenario who hasn't then gone on to decide to have standard medical therapy. But it is a very difficult situation to deal with, and I don't know how you deal about it in general. I only know how I deal with it in my clinic.
But you do see it. You do see that people coming and saying,
yeah.
"Look, there's this ivermectin now."
Yeah.
Here's this celebrity saying it. Really, it's just miraculous.
Yeah, it's a difficult one for sure.
Yeah, fantastic work.
Thanks.
There should be a trigger warning on the word ivermectin after the last 5 years of work I've done trying to dispel the myths of ivermectin. But I'm okay. I'm calm. Russell Petty has just commented, this is the final comment. Great point, and the success of immune checkpoint inhibitors has opened the floodgates for many other immunotherapies, which are in early and later phase trials, including personalized cancer vaccines, which we are trialing. I think that's locally. He means that we're doing that. And I predict in 10 years, all systemic cancer therapy will be immunotherapy, ... So there is the potential that we're back in another 10 years of grand rounds where we're talking at someone from your oncology is saying, remember when we used to give platinum-based chemotherapy? When we used to give docetaxel to people? We don't do that anymore at all, and we're just on immunotherapy. Well, that would be very interesting. And if you're still around, then you're welcome back. Russell has put his hand up because he's found the button, Tony. So he's going to have the final say for this grand round before I wrap things up. Russell, hello.
Thanks, Joe. Found the button, Tom. I would suggest to colleagues this is the tip of the iceberg. Checkpoint inhibitors are just the first in their class, and the expansion of therapeutics in cancer immunotherapy is phenomenal. bispecific antibodies, personalized cancer vaccines, cell-based therapies. It's just the tip of the iceberg. And as Lauren has made the point perfectly, the big transformative impact of these treatments is able to provide durable, long-lasting responses in the likes of which we'd never seen before in cancer patients, including, as you mentioned, Tom, I think I heard previously untreatable diseases from a systemic point of view, such as melanoma. So this is, we're putting a marker down. This is, by the time I retire, I think cancer immunotherapy will be everything. Chemotherapies diminishing. And I think targeted therapies that are non-immunotherapies are becoming less and less important. That's how big it is. So that's the point. Thank you for giving me the last word, Tom. That's really good of you.
My pleasure. My pleasure. So they'll bring to the end another really fascinating and interesting ground rounds. I love it when we come full circle, when we've had a talk in the last, we've been doing this for what, 11 years now, and we come full circle back to something we talked about before, and it's a new face talking about it. But it's a shame we don't have recordings as far back as Lecture Theatre 2, so I can't point you towards the previous discussion. But it really is interesting to me to come full circle for these sorts of things that I sit on the periphery of in lung medicine, but I don't do cancer, so I really do sit on the periphery of all this looking in, and it's really fascinating to me, and I hope the general audience find this sort of thing very interesting. And if you're sat there thinking you have a similar talk that you'd like to give, which would be just as interesting, or you spoke a few years ago and you have an update, if you have something you'd like to come and talk to us about, then let me know, because I've got slots in the Grand Round programme as early as the 19th of February, all the way through until June when we finish up for the summer. So do let me know. Okay, thanks very much, everyone. Have a good weekend, although it's going to rain and I'm on call. So have a good one, and I'll see you next week.
Thanks, everyone. Bye.